Hi everyone. Welcome to week 4 of the nephrology teaching rounds for rotating clerks and residents. We've put together a series of videos containing core nephrology content for your rotation to be delivered in a flipped classroom style. If you're joining us for the first time, these videos are set up as a flipped classroom and involves listening to a 20 to 30 minute podcast each week focused on a specific topic in nephrology. Each week, there will be a tutorial to review specific cases related to that topic, which can be found ahead of time on Dropbox. This week, the topic is on kidney transplantation, an important aspect of nephrology for patients facing kidney failure. As a reminder, this is our friend Jerry the glomerulus, who will be joining us throughout this video cast and highlighting important high-yield areas to remember. The outline of today's talk will start off with why transplant, the process of transplantation, identifying who gets a transplant, followed by some basics on immunosuppression, as well as things to watch out for when dealing with kidney transplant patients. But let's start off with some of the history of kidney transplantation. The first solid organ transplant occurred in the 1950s, but many of these failed due to a lack of immunosuppression. It was in Boston in 1954 that the first successful kidney transplant was completed between two identical twins, Richard and Ronald Herrick. Since they were identical twins, there were fewer problems with immune reactions. However, the recipient, Richard, still passed away 8 years after his transplant. In Alberta, the Southern Alberta Transplant Program, also called ULTRA, had the first successful kidney transplant in 1971, and currently ULTRA follows approximately 1,000 active kidney recipients and completes about 80 to 100 transplants per year. When we look at the national statistics for kidney transplant, in Canada, approximately 1,700 kidneys are transplanted every year. However, there still remains almost 3,000 patients who are waiting for a transplant, and sadly, about 100 patients die each and every year on the waiting list. Kidneys remain the most transplanted organ in Canada, outnumbering all other organ transplants combined. And when we look over a 10-year period, the number of donations continues to rise, but this is largely driven by deceased donors. This is true not only nationally, but also reflected in the province in Alberta. Now, the question you might be wondering is why bother with kidney transplant in the first place? The truth is that for most patients who are fortunate enough to receive a transplant, there is a mortality benefit compared to being on dialysis. The adjusted mortality rate on dialysis is stated to be as high as 15 to 20% per year and 50% over 5 years. The specific reasons for this are multifactorial and include the fact that dialysis is really unable to compensate or replicate the full filtration of a kidney, and over time can lead to buildup of uremic toxins. These toxins likely contribute to higher cardiovascular morbidity, incidence of vascular disease, and general organ dysfunction such as anemia and mineral bone disease. Thus, it's pretty clear that giving someone a new kidney could fully prevent or even reverse some of these consequences associated with dialysis. For most individuals with end-stage kidney disease, we know that transplant not only improves survival, but also comes with an improvement in quality of life. However, wait times still remain a significant barrier, and for example, having O-positive blood group could mean that you might be waiting on the transplant list for 6 years or more until you receive your transplant. Moving on, there are two major classes of kidney donation: donation through a living donor or through a deceased donor. You might hear some of these terms being used on your transplant rotation. As you can probably guess, a living donor means that the organ has come from an individual, either of blood relative, or what we call as a living related donor, or LRD, or a living unrelated donor, also called LURD. A donation from a living donor has many advantages, including possibly shorter wait times, better graft performance after surgery, and decreased complications such as delayed graft function. Additionally, the possibility of even having a preemptive transplant, in other words, before a patient receives dialysis, in some case may result in better outcomes for patients. On the contrary, deceased donation occurs after a donor has passed away. This is further subclassified as donation after circulatory death, or DCD, or neurologically determined death, or NDD. The majority of transplants in Canada performed are NDD donors, although there's been greater resurgence in the last several years of DCD transplants. DCD donation occurs after cardiac death, meaning the donor must be in asystole at time of procurement in some centers. The donor is then rushed to the operating room for procurement. In NDD, for example, after an unsurvivable hypoxic brain injury, the organs are procured while still being perfused, as there is no cessation of cardiac activity. There are many nuances between the two types of procurement, which are above the scope of this presentation, but needless to say, both are viable options that are currently practiced in Canada. You may also hear the terms expanded or exceptional donation used in reference to donors. Expanded criteria refers to donors who are greater than the age of 60, or donors between the ages of 50 and 59 with two of the following criteria: a creatinine greater than 132 at time of donation, a history of hypertension, or CVA as a mechanism of death. Exceptional distribution, on the other hand, refers to high-risk donors who may have an increased risk of passing a communicable disease, such as donors with an unknown sexual history. Fortunately, screening programs ensure that the risk to recipient is still very low, however, is not negligible. This leads to the big question of who is even able to get a transplant? With so many patients on dialysis, the natural question is, why do so few patients become eligible for transplantation? In Canada, there are several high-priority groups depending on their medical status. The 6 groups that fall under this status include being a prior organ donor, medically urgent transplantation, highly sensitized patients, patients receiving combined organ transplantation, pediatric recipients, as well as HLA-identical recipients. These categories can vary from province to province and country to country. Patients that do not fall into any of these categories are still considered for transplantation, but are not given special priority. When a patient on dialysis is referred for transplant, one of the first things they will need to do is to attend a pre-transplant assessment with a transplant nephrologist. This assessment consists of a very thorough chart review, including understanding their history of kidney disease, a cardiac, infectious, and malignancy screen, as well as social complexities which may impact their candidacy for transplantation. A physical exam should be completed to identify any concerning findings, such as hernias or poor vasculature, that may complicate surgery. Investigations are reviewed to answer any of the unclear questions that may have arisen from the history of physical exam. And during this assessment, the transplant process is reviewed with the patient to include any additional consultations or investigations that may be required from the transplant team. It's also important that at this time, the risks and benefits of transplant are discussed with the patient. Some patients with significant medical comorbidities may not actually benefit from any survival standpoint following transplant due to the risk of surgery as well as risk from chronic immunosuppression. And during the first 6 months post-transplant, transplantation is actually associated with a small increase in mortality, which is important to clarify with the patient. At the assessment, we also talk to patients about whether or not they would be willing to accept an expanded criteria or exceptional distribution organ. As you recall from earlier, there are specific criteria as to what constitutes expanded criteria. Incorporating expanded criteria organs as part of the transplant pool has vastly increased access to patients who may otherwise receive an ideal organ match, given the long wait times. These organs may be ideal for patients who are thought to confer a survival advantage from transplant, however, still have a limited life expectancy due to their age. For example, a patient in their 60s on dialysis compared to a patient in their 20s. Since the life expectancy of a graft may not necessarily extend past the patient's life expectancy, expanded criteria organs may still provide a survival as well as quality of life advantage for patients who do not require decades of transplant function. All of this to say that while most patients can be assessed for transplant, those that are likely to not continue in the transplant process are those with limited life expectancies, poor surgical candidates, those with active malignancies or multimorbidity, to name a few. In Canada, the major barrier to transplant still remains a limited organ supply, and many patients who would otherwise qualify for transplant are still waiting years for the right organ. Once they have passed all the assessments and consultations, the patients are reviewed by a multidisciplinary board to be listed for transplant. After this point, the waiting begins. For those fortunate to be called to hospital to receive a transplant, the process is fairly straightforward. Usually the patients will arrive the day prior to surgery for a last-minute medical clearance as well as dialysis. After receiving the transplanted organ, they usually remain in hospital anywhere between 7 to 10 days to receive their induction immunosuppression as well as monitoring graft function. Assuming all goes well, patients can look forward to be discharged home thereafter with close follow-up with the transplant clinic. There's very close post-operative follow-up in the initial 6 weeks, and depending how the patient and their graft are doing, this will gradually be increased in duration. Unfortunately, some patients suffer from something called delayed graft function, or DGF. The definition of delayed graft function is the need for dialysis post-transplant within 7 days of surgery. This can occur from a number of reasons, and our usual approach is similar to that of an AKI following the same schema of pre-renal, renal, and post-renal. In the pre-renal category, patients may have hypovolemia or hypotension during the surgery or bleeding. The graft itself may also be impaired due to prolonged cold ischemic time, which could in turn result in ATN. Abnormalities to the vasculature, such as an occlusion of the renal artery and vein, also lead to high-risk consequences and delayed graft function. And, unfortunately, in some cases, patients may also have acute graft rejection or a recurrence of their primary renal disease. Post-renal causes are a little bit more extensive than those that we typically think about in the non-transplant patient. This includes surgical complications, including clots, which could block the Foley catheter, a perinephric collection, or a urine leak. Needless to say, delayed graft function is a serious complication that requires urgent investigations and possibly further investigations. Moving along, it's probably time we talk about the biggest elephant in the room about transplant, and that is the immunosuppression that follows after implantation. There are 3 main signals which are targeted to limit cell and antibody-mediated rejection, and immunosuppression regimens are broken down into induction and maintenance therapies. In induction immunosuppression, the main arms that we are trying to target include T and B cell depletion, calcineurin inhibition, as well as antimetabolite therapy. T and B cell depletion is critical to preventing cellular and antibody-mediated rejection, and this is typically done through either antithymocyte globulin, ATG, or basiliximab. Similarly, corticosteroids, through multiple mechanisms, also inhibit graft rejection through T and B cell pathways. The second arm includes blocking calcineurin, which is a serine threonine protein phosphatase. Calcineurin activates the transcription factor NFAT-C, which is then able to translocate to the nucleus and upregulate expression of interleukin-2. This upregulation is critical for the growth and differentiation of T cells. Lastly, the third arm of immunosuppression consists of inhibitors of nucleotide synthesis, primarily mycophenolate or leflunomide. These medications typically interfere with DNA synthesis, which is important as most immune cells are derived from highly replicating cell lineages. After induction comes maintenance immunosuppression. Similar to induction therapy, maintenance immunosuppression includes steroids, typically dosed at 5 mg per day after the initial steroid taper, calcineurin inhibitors, as well as an antimetabolite. For unclear reasons, prednisone, even at low doses, has been associated with a decreased risk of T-cell mediated rejection. On the other hand, calcineurin inhibitors need to be followed closely with drug levels, as this typically decreases further away the patient is from their transplant. The most common antimetabolite used is mycophenolate. In patients intolerant of this medication, alternatives exist, such as azathioprine, which can be used instead. As I alluded to earlier, immunosuppression is not a benign therapy and is associated with a whole host of side effects. Almost every medication that we use in immunosuppression has unique side effects which need to be monitored closely. Starting from induction, anti-thymocyte-globulin, or ATG, which is only used in high-risk patients, can lead to infusion reactions such as fevers, hemodynamic instability, and chest and back pain. It is also associated with myelosuppression, which can then lead to increased viral infections by infectious agents such as BK and CMV. Lastly, due to the potency of immunosuppression, ATG has been associated with a higher risk of post-transplant lymphoproliferative disease, or PTLD, as well as non-melanoma skin cancers. Prednisone, which is a mainstay for T and B cell mediated rejection, has many long-term side effects including hypertension as well as new onset diabetes after transplant, which we commonly call as NODAT. Similarly, calcineurin inhibitors can cause hypertension as well as NODAT, but is also associated with thrombotic microangiopathy and certain neurological symptoms such as a tremor or neuropathies. Antimetabolites, meanwhile, are typically associated with marrow suppression, but specifically to mycophenolate, it is associated with increased GI side effects, particularly diarrhea. Now, assuming you get through the surgery, induction, and maintenance therapy, a big question that's quite common from patients is, how long will my kidney last? This in turn is quite variable. Patients with severe disease recurrence or antibody or cell-mediated rejection can have their graft last as little as a year, which is quite a tragedy when you think about the risks imparted to the recipient. However, if all things go smoothly with no signs of rejection and no surgical complications, a graft can survive from up to 10 to 20 years. Things that mediate graft survival include medication non-adherence, comorbidities such as congestive heart failure or cancer, particularly if patients are to receive cytotoxic chemotherapy, or, as mentioned earlier, graft rejection by cell or antibody-mediated mechanisms. So how do you identify graft rejection? The challenge with graft rejection is that patients are typically asymptomatic, similar to those with worsening chronic kidney disease. Typically, patients are noted for an acute or grumbling increase in their creatinine with a concomitant decrease in their GFR. They may also have new or worsening proteinuria or hematuria. On the other hand, hyperacute graft rejection occurs quickly, usually within days to weeks after implantation. This presents as more of a catastrophic rejection of the graft with heavy immunological response leading to fevers, oliguria or anuria, shock, or pain over the graft. Hyperacute graft rejection is uncommon, but when it does occur, is associated with poor graft prognosis and increased morbidity to the patient. Alright, so in the last part of the presentation, I want to review with you what you might encounter with a transplant recipient as an internal medicine resident. In our center, anyone who has received a transplant greater than 1 year ago is usually admitted to the internal medicine or hospital service, so it's not uncommon that you will encounter a patient with a prior transplant history. The first thing you should remember is that the transplant service is staffed 24/7, 365, so anytime you admit a patient to hospital with a kidney transplant, it's worthwhile giving them a call just so they can provide some advice around immunosuppression management. Outside of that, patients with an acute kidney injury for whatever reason should be treated exactly as the same as you would in a patient without a graft. This means going back to basics, checking electrolytes, creatinine, and a urinalysis. You really want to make sure to figure out what their baseline creatinine is because not all transplant recipients return to a normal creatinine after transplantation. In general, your approach to an AKI should be identical following the schema of pre-renal, renal, and post-renal. Some nuances do exist, however. For patients on tacrolimus, as part of their immunosuppression, it's fair to send off a trough level, which is typically first thing in the morning before they've taken their morning dose. Sending off a stat tacrolimus level is usually not helpful and very difficult to interpret. The second thing is that with acute kidney injuries in a transplanted kidney, it's always not a bad idea to send an ultrasound with Doppler to assess perfusion of the graft. Two investigations that I would not recommend, and until you've discussed with a transplant nephrologist, include sending an HLA panel as well as obtaining a graft biopsy. These really have no utility in the acute setting, and if you're that worried about a failing graft, you really want to make sure that the transplant nephrologist is involved and notified in the patient's care prior to sending them for a biopsy. With regards to their immunosuppression, there is actually very limited guidance on what you do with their medications. What we typically recommend is that patients coming in with an infection is to hold the mycophenolate or other antimetabolite. If the patient is hypotensive, it's not unreasonable to give stress dose steroids. However, this is generally only required if they are hypotensive or demonstrate signs of shock. Otherwise, continuing their home dose of prednisone as well as tacrolimus or other calcineurin inhibitor is usually a reasonable approach. Keep in mind that the tacrolimus level can easily become supratherapeutic, particularly in the context of an acute kidney injury or counterintuitively in patients with diarrhea. Once a patient has been stabilized and appears to be turning the corner, you can look at restarting the immunosuppression after 24 to 48 hours. Again, there's very limited guidelines as to what to restart and when. However, one recommendation is to restart the antimetabolite at a 50% dose after 24 hours, and if they continue to become stable, to restart the home dose shortly thereafter. All of this said, there are a few additional red flags that I would caution you about when dealing with the transplant recipient. The first is that because of their immunosuppression, many times they may have a normal WBC, and so if you suspect that the patient has an infection, I would recommend treating this rather aggressively, even though you may not have an elevated white count. Particularly in patients with a rapidly deteriorating kidney function, especially those with uremia, hyperkalemia, or volume overload, you really need to worry about graft failure, and your first call should be to the transplant nephrologist for additional guidance on management. Transplant patients also do not experience pain over the graft site compared to normal patients. Remember that the implanted kidney is denervated, so they may not actually have the same type of flank pain that you typically expect in patients with pyelonephritis. Instead, they may only have redness or swelling over the graft, and typical UTI symptoms or pyelonephritis symptoms may not be as anticipated. Lastly, due to their immunosuppression, you really need to watch out for atypical infections. This includes PJP and CMV. In light of the recent COVID-19 pandemic, it has also been reported that transplant patients have an estimated 30% mortality due to their immunosuppression. So again, you need to have a high suspicion if you suspect COVID, but also treat fairly aggressively. Remember that the transplant service has someone on call every day of the year, 365. So don't be afraid to call if you have any questions when dealing with transplant patients. This wraps it up for this episode of the Nephrology Teaching Rounds. I hope you enjoyed this episode, and certainly we welcome your feedback, which you can send to our nephrology program administrator. Remember to look at the cases on Dropbox, and we look forward to seeing you at our in-person case discussion later in the week. Till then,